Welcome to the Deep Dive. Today we're plunging into a topic that sounds incredibly precise, almost like something out of a futuristic medical drama. But trust me, it's bursting with incredible insights into how modern medicine saves lives and the sheer ingenuity involved.
Exactly. We're going on a deep dive into some critical complications that can arise after liver transplantation specifically, the vascular issues, hepatic artery thrombosis, hepatic venous outflow obstruction, and portal vein thrombosis.
You shared some fascinating research with us, and our mission today is to, well, demystify the medical language, extract the most important insights, and really get a handle on what these complications are, why they matter, and how doctors are dramatically improving patient outcomes.
Right. We'll look at how often they happen, the sometimes surprising ways they show up.
Yeah, how they're diagnosed, and the cutting-edge treatments that can truly make the difference between success and failure.
Absolutely. And as we'll see, detecting these issues early is it's absolutely crucial.
Okay, let's start with the first and often most feared vascular complication, hepatic artery thrombosis, or HAT. It's flagged as the most serious, even though it's relatively rare, appearing in about, 2% to 9% of adult liver transplant recipients these days?
That's right. But the reason it's so feared, it's the potential for devastation.
Okay.
If it's not recognized or treated quickly, acute HAT can lead to the new liver failing or even patient death in up to 50% of cases. 50%.
Wow.
It accounts for more than half of all arterial problems after a liver transplant and is a leading cause of the new liver just not working right away.
So even though it's not super common, the consequences are severe.
Exactly. Though, thankfully, the overall incidence has declined over time due to better surgical techniques.
50% graft failure. That's a truly stark number.
Yeah.
So what are the primary reasons this kind of critical failure can happen? What are the biggest risk factors we should know about?
Well, the research overwhelmingly points to technical factors as being paramount.
Surgical issues, basically.
Yes, precisely. We're talking about the surgical precision of the hepatic artery anastomosis. That's the crucial connection point where the surgeon connects the donor's artery to the recipient's.
Okay.
Any kind of intimal injury damage to the inner lining of the vessel or problems like a size mismatch between the arteries, any kinking or too much tension right at that connection point, all that can set the stage for a clot.
So it's incredibly delicate work.
It really is. And it's a testament to surgical advancement. That meticulous microvascular technique, using magnification like a microscope or surgical loops, has significantly reduced HAT incidence.
Right.
From a historical high that was sometimes over 20% down to as low as 0.2% in some centers now.
That's a massive improvement. It sounds like every millimeter of that connection is absolutely vital. What else adds to the risk? I imagine time is a factor in these long, complex procedures.
Crucially, yes. Prolonged time that the liver is without blood flow during the surgery. That's the ischemia time, and the sheer complexity of the operation itself also elevate the risk. Well, one really striking finding indicates that for every additional 10 minutes of delayed blood flow restoration, the risk of early HAT increases by about 27%.
27% for every 10 minutes. Wow.
Yeah. It really underscores how every minute counts in that OR. Efficiency becomes a critical part of surgical success. Operations going over 10 hours or really difficult situations like unexpected clots popping up elsewhere or significant bleeding, that all compounds the risk.
Okay, so surgical technique, time. What about the patient or donor factors?
Right, it's not just surgical. Recipient and donor factors play a role too. Things like a big size difference between the donor and recipient, or urgent retransplants where blood vessels are often scarred from previous surgery.
Makes sense, harder to work with.
Exactly. And even underlying conditions like hypercoagulable states where blood clots more easily, like in factor V Leiden or active smoking, can contribute to early HAT. Some studies have suggested links for late onset HAT too. Things like using a liver from a CMV positive donor or a female to male gender mismatch, possibly due to immune-mediated damage to the vessel lining. But those connections are maybe less consistent across studies.
Interesting.
And definitely, if the artery needs complex reconstruction, maybe using an interposition graft, or if the connection has to be redone, the risk jumps dramatically. One study showed needing an arterial reconnection made the risk for early HAT more than 4 times higher.
4 times.
Oh.
Okay, so when HA does strike, what exactly is happening inside the liver? Why is it so devastating for the organ itself?
Yeah, this is a critical point. The reason HAT is so devastating is because the hepatic artery is the only source of arterial blood flow to the new liver graft.
Right.
Now, the main liver tissue, the paraminga, it gets blood from 2 sources, the hepatic artery and the portal vein. But the biliary tree, that complex network of bile ducts, it's entirely dependent on the hepatic artery for its oxygen.
Ah, I see. So HAT specifically starves the bile ducts of oxygen.
Precisely. It uniquely causes biliary ischemia. This leads to rapid tissue death in the ducts and potentially in the liver tissue too. And that results in severe complications: bile leaks, strictures or narrowing, infections like cholangitis, and abscesses.
Nasty stuff.
Very. In acute, complete HAT, there's just no time for the body to develop natural bypasses,
Ah.
collateral circulation, so you can get massive liver damage, widespread infection, sepsis. It can happen very quickly.
But you mentioned collaterals sometimes form.
Yes, if HAT develops more slowly, or if it's only a partial blockage, the body might have time to form these collaterals, little bypass vessels from other nearby arteries, like the ones supplying the diaphragm or stomach.
And that explains the difference between early and late HAT presentations.
Exactly. It explains why late HE often has a more gradual, sort of indolent course,
Oh.
focused more on those biliary complications rather than immediate fulminant liver failure.
That distinction, early versus late, sounds crucial then. How does the body's response in the presentation differ based on when HAT occurs?
Clinically, early HAT, which is the most common type and usually happens within the first month or so after transplant, typically presents with abrupt and severe signs.
Like what?
Patients might show rapidly rising liver enzymes, bilirubin climbing, clear signs the new liver is struggling, and sometimes acute damage to the bile ducts leading to a bile leak or infection inside the abdomen, what we call biliary peritonitis. Systemic signs like fever and sepsis are pretty common too.
Okay, so pretty dramatic.
It can be. But here is a truly pivotal insight from the research you sent over. In one series, a remarkable 66% of early HAT cases were initially asymptomatic.
66%. Asymptomatic.
Yes, no outward symptoms at all. They were only identified because of routine Doppler ultrasound screening done within days of the transplant.
That's incredible. So without that routine check, they might have gone undetected until it was catastrophic.
Precisely. It completely changed post-transplant monitoring. It forced this shift from just reacting to symptoms to proactive, almost obsessive surveillance. It really shows how data can drive a total paradigm shift in care and help avert disaster.
That's a powerful point, that something so devastating can initially be silent. So what about late HAT? How does that tend to present differently?
Late HAT tends to have a subtler or maybe subacute presentation. It happens months to years later, typically around 6 months is the median.
Still potentially silent, though.
Yes, up to half of these late cases might also be initially asymptomatic, just picked up on routine blood tests showing unexplained abnormal liver function.
And when symptoms do occur in late HAT,
They usually relate to that ongoing damage to the bile ducts from lack of blood flow. So recurrent cholangitis, that's infections causing fever and right upper abdominal pain, or bile duct strictures, liver abscesses.
okay.
Unlike early HAT, severe sudden graft failure is less common in late HAT because, as we said, some arterial flow is often maintained via those natural bypasses, those collaterals.
So, summarizing, acute early HAT often means liver infarction and sepsis, whereas late HAT is more about chronic biliary problems with maybe milder liver dysfunction.
That's a very good way to put it, yes.
With such a range of presentations, how do doctors actually diagnose this? What are the go-to tools for catching it, especially in those silent cases?
Imaging. Imaging is absolutely key. And Doppler ultrasonography, or DUS, is really the cornerstone of HAT diagnosis.
That's the routine screening tool you mentioned.
Exactly. It's used routinely right after surgery, often daily for the first 5 to 7 days, specifically to check if the blood vessels are open and flowing freely.
What does it show if there is HAT?
It might show just a complete absence of detectable flow in the hepatic artery or its branches. Or sometimes it shows indirect signs like a specific abnormal waveform pattern called tardus et parvus.
Tardus et parvus.
Yeah, it basically means the normal sharp pulse of blood flow becomes dampened, slow to rise, almost like a weak, delayed signal. It's a sign of blockage upstream.
And this ultrasound is sensitive enough to catch it early.
It often is, yes. It's so critical that it frequently detects HAT even before severe symptoms develop, which allows for that crucial early intervention.
What about confirmation, if the ultrasound is suspicious?
Then usually a contrast-enhanced CT angiography is done. That can directly visualize the clot and show a lack of blood flow or enhancement in the liver's arterial supply.
And the gold standard.
The gold standard, though, is conventional angiography. It gives the clearest picture, confirms the diagnosis, and importantly, it can often be combined with treatment in the same procedure.
Right, treatment. Once HAT is confirmed, what's the plan? This sounds like a real race against time.
It absolutely is a surgical emergency when it occurs acutely. Management needs a multidisciplinary approach, surgeons, interventional radiologists, intensivists, all working together.
What are the immediate goals?
The immediate goals are 1, rapidly restore arterial blood flow to the new liver if possible, and 2, prevent or manage those dangerous biliary and infectious complications.
How do they restore flow?
Well, endovascular therapy, done by interventional radiologists or IR, has increasingly become the first-line approach, especially for early HAT when it's feasible.
What does that involve? Minimally invasive stuff.
Exactly. Techniques like catheter-directed thrombolysis, where they thread a catheter to the clot and infuse clot-busting drugs like TPA directly into it, often combined with angioplasty, using a balloon to open the vessel and maybe placing a stent to keep it open.
And how successful is that?
It can successfully reopen the hepatic artery in a good number of cases, maybe 50–70% reported success rates.
Okay, but what if that doesn't work or isn't an option?
Right. If endovascular therapy isn't quickly available, or if it fails, or if the patient is just too unstable, then urgent surgical revascularization is needed.
Back to the operating room.
Yes, that could involve the surgeon removing the clot and redoing the connection, or sometimes creating a whole new bypass using a different vessel, like a jump graft from the splenic artery or even the aorta.
And the last resort.
Ultimately, if the hepatic artery just cannot be successfully reopened, or if the liver graft has already suffered too much damage, then emergent retransplantation is the definitive solution.
Another transplant.
Yes, though obviously that carries substantial risk itself. Retransplant rates are somewhere around 30–50% in early H8 cases.
And regardless of how they restore flow, infections are a big concern.
Huge concern. Broad-spectrum antibiotics and managing any source of infection are essential. And usually, blood thinners, anticoagulation, or antiplatelet therapy are started once the bleeding risk is under control to try and prevent the artery from clotting off again.
Given all of this, what's the prognosis like for patients who experience H8? And maybe more importantly, how do they prevent it in the first place?
Well, unfortunately, HAT is associated with the worst prognosis of any of these vascular complications after liver transplant. Early HA particularly carries high rates of morbidity and mortality if it's not addressed rapidly.
We heard the numbers graft loss or urgent retransplant in over half, mortality approaching 50% in severe cases.
Exactly. It's very serious. But here's the somewhat brighter side. If a patient's graft and life are salvaged after HAT, whether through successful revascularization or a retransplant, their long-term outlook can actually approach that of other transplant patients without this complication.
So recovery is possible.
It is, which makes prevention even more critical.
And prevention comes back to
Meticulous surgical technique. As we discussed, using an operating microscope or surgical loops for that delicate arterial connection is the absolute first line of defense.
and the screening.
And the routine postoperative Doppler ultrasound surveillance. Doing it within hours of surgery and then daily for the first 5–7 days is a widely adopted, crucial preventive strategy. That early screening allows for catching HAT asymptomatically before the liver is irreversibly damaged.
It's amazing how that vigilant surveillance can turn a silent threat into a potentially manageable problem. Beyond the surgery and the imaging, are there any other new developments, maybe on the medication side, to prevent these clots?
That's a great question, and yes, there's definitely some exciting progress there. While giving everyone strong blood thinners isn't routine because of the bleeding risk,
Right, it's a balance.
it's a very delicate balance. But recent evidence points towards a benefit from prophylactic antiplatelet therapy, basically, giving medication like low-dose aspirin to prevent platelets from sticking together specifically in high-risk patients.
Oh, interesting. Like, who is high risk?
Well, a recent study from 2024 identified certain scenarios, maybe complex reconstructions, previous clots, etc., and found that giving low-dose aspirin for 3 months after the transplant cut the rate of early HAT from 21% down to just 3% in those specific high-risk patients.
Wow, from 21% to 3%.
Yes, and importantly, it did so without causing a significant increase in bleeding complications.
That's key.
Absolutely. So based on this kind of accumulating data, some transplant programs are now routinely giving low-dose aspirin to all adult recipients, or at least selectively to those identified as high risk right after transplant. The International Liver Transplantation Society even recommends considering antiplatelet prophylaxis for all liver transplant recipients now.
That sounds like a subtle but Potentially impactful shift in practice.
It is. It's a great example of how precision medicine continually refines care and improves outcomes.
Okay, so if HAT is about the crucial supply line getting cut off, let's shift gears to hepatic venous outflow obstruction, or HVOO. This sounds like the opposite problem. The drains are blocked, right?
Yeah.
Causing a kind of internal pressure backup in the new liver.
You've got it exactly right. HVOO is any compromise of the venous drainage from the new liver. This could be a narrowing, a stenosis, or a clot, a thrombosis in the hepatic veins themselves, or in the main large vein, the inferior vena cava, IVC, where they connect.
Functionally like Budd-Chiari syndrome.
Very much so. It's like Budd-Chiari syndrome happening in the transplanted liver blood, simply can't get out effectively.
How common is this one?
It's relatively uncommon, thankfully, typically estimated at less than 1 to 3% incidence. But like HAT, it can be catastrophic if it's severe.
And more common in certain types of transplants.
Yes, it's seen a bit more frequently in living donor or split liver transplants. That's mainly due to the added complexity of connecting multiple, often smaller hepatic veins in those situations.
So what specifically causes this backup of blood? What are the main risk factors here? Is it surgical again?
Overwhelmingly, yes, the research is clear. The key risk factors are almost entirely technical and surgical.
Like what specifically?
Things like the surgical creation of that venous connection, the anastomosis being too narrow or maybe sort of funnel-shaped, or simply mispositioning or kinking of the new liver graft itself, especially if the connection to the IBC is too long or not quite aligned correctly.
And that piggyback technique.
Right, the piggyback technique, where the donor's hepatic veins are sewn onto the side of the recipient's own IVC, which is left in place. It's widely used and generally very effective. But if it's not done just right, it can predispose to outflow issues. There's a slightly increased risk of the IVC connection narrowing or clotting, maybe around 1.6% in some series.
It really does sound like another case where surgical precision is absolutely everything, like getting the plumbing perfectly aligned and sized.
It absolutely is, especially in living donor transplants, where surgeons might need to reconstruct several small hepatic veins into one larger outflow, or maybe use a vein graft to bridge a gap. These can be quite challenging.
And if they don't get it quite right,
If all the outflow veins aren't completely incorporated into the connection, it can restrict flow. Having multiple hepatic veins to connect or needing a narrow repair in living donor cases is a known risk scenario for HVOO.
what about later on? Can it develop over time?
Yes, later onset obstruction usually reflects what we call a fibrotic stenosis. That's basically scar tissue forming or the inner lining of the vein thickening right at the surgical connection point over weeks or months, gradually narrowing the veins.
So surgeons are aware of this risk.
Oh, absolutely. Many centers now use a modified piggyback technique that creates a really large common opening incorporating multiple hepatic veins, and that has been shown to significantly reduce the incidence of HVOO.
Okay, so what's actually happening inside the liver when this outflow gets obstructed? How does the liver react to this kind of congestion?
Well, the pathophysiology, as we said, is very much like Budd-Chiari syndrome. Impeded venous drainage causes blood to back up. This leads to sinusoidal congestion.
The sinusoids are the tiny blood vessels within the liver.
Exactly. Think of the liver like a sponge filled with these tiny blood channels. When the drains are blocked, blood backs up intensely in these sinusoids. This causes the liver to swell, become quite tender, and leads to increased pressure inside the liver, which impairs its function.
And in severe cases?
In severe cases, this intense congestion can lead to something called centrilobular hemorrhagic necrosis, essentially severe internal bleeding and cell death occurring right in the central parts of the liver's functional units because the pressure is just too high.
That sounds bad. And the timing. Can HVO show up early or late?
Both. It can appear acutely within days of the transplant, especially if there is an immediate postoperative clot or maybe a twist in the outflow tract.
A technical issue right away.
Right, sometimes called acute Budd-Chiari in the graft. Or it can be more subacute, developing over weeks to months, typically if a narrowing, a stenosis, is gradually worsening over time.
So early HVO is often technical. Late HVO is more about that scarring or fibrosis.
That's generally the pattern, yes. Late HVOA, usually beyond 3 months or so, is typically due to that fibrotic anastomotic stricture or maybe chronic thickening of the vein wall.
What are the visible signs then? What might you see in a patient with HVO? What does this internal congestion look like clinically?
The clinical features mirror Budd-Chiari syndrome and also severe right-sided heart failure. Because the liver is essentially engorged with blood, it can't pump out.
So what does the patient experience?
In early acute HVOO, patients might develop a tense, painful, enlarged new liver, what we call hepatomegaly. Often they get rapidly accumulating refractory ascites, that's fluid buildup in the abdomen that's really hard to treat with diuretics because the pressure inside the liver is just so high.
Right.
They might even experience reduced urine output, oliguria, or even acute kidney injury because the congestion can affect kidney perfusion. Swelling in the lower legs, peripheral edema can happen if the main IVC outflow itself is compromised. And in very severe cases, patients can become hemodynamically unstable.
Are there any specific clues for the less acute forms?
Yes, here's a key clue for you. For subacute or partial HCOO, it often presents with unexplained ascites and sometimes hydrothorax, that's fluid buildup in the chest cavity, usually on the right side appearing maybe a few weeks after the transplant.
Fluid in the belly and the chest.
Right. The liver function tests might show a cholestatic pattern, indicating problems with bile flow due to the congestion. And unlike HAT, there's typically no fever unless there happens to be a superimposed infection.
Any other subtle signs?
Another potential clue is differential edema, like really pronounced leg swelling, or that rapid onset of large volume ascites that seems kind of out of proportion to how much the liver enzymes have changed.
Okay. And how do they diagnose it? How do doctors actually see that congestion and confirm the blockage?
Again, imaging is critical, and Doppler ultrasound is the first-line test.
What does Doppler show here?
Well, normal hepatic vein waveforms on Doppler are triphasic. They have this distinct up and down three-phase pattern reflecting normal blood flow variations with the cardiac cycle.
Oh,
In outflow obstruction, these waves become flattened or monophasic. They lose that normal pulsatile rhythm, which is a very clear sign of restricted flow out of the liver. Doppler can also sometimes directly visualize the narrowing at the connection or even see a clot.
and if the ultrasound is suggestive?
Then, usually a contrast-enhanced CT scan, specifically a CT venogram, or an MR venogram is obtained to get a more detailed map of the anatomy and the blockage.
But the definitive test?
The definitive diagnostic test is venography.
Mhm.
This is usually done via a catheter threaded either through the jugular vein in the neck or sometimes directly through the liver.
Like the angiography for HAT.
Exactly. This cavography, as it's called when imaging the vena cava and hepatic veins, directly visualizes the anastomosis, the connection point. And crucially, it allows for direct pressure measurements across the blockage.
How much pressure indicates a problem?
A pressure gradient of more than 10 millimeters of mercury across the stenosis is generally considered significant. And the beauty is, if they find a significant blockage, they can often proceed with intervention right then and there.
Right, treatment. So once this kind of obstruction is found, how do doctors effectively unclog the drain and restore that vital outflow?
Well, percutaneous interventional radiology, IR, is typically the first-line therapy here, especially for a narrowing or maybe a mild clot at the anastomosis.
What do the IR docs do?
Under X-ray guidance, they perform balloon angioplasty. They inflate a small balloon across the narrowed segment of the hepatic vein or IVC connection to stretch it open.
Is ballooning enough?
Often, it's followed by placing a stent, especially if the narrowing seems elastic and likely to spring back, or if it recurs later. Re-narrowing or restenosis is fairly common after just balloon angioplasty alone. Large, self-expanding stents placed in the IVC or hepatic vein can do a good job of maintaining long-term patency.
And this IR approach is preferred over surgery?
Generally, yes. It's much less invasive, and it has high success rates. Reports range from around 73% up to even 100% sustained relief in some studies.
When would surgery be considered?
Surgical revision is usually reserved for cases where IR fails or perhaps isn't immediately available. In an early postoperative HVOO that's caused by simple kinking or a twist, sometimes surgical reexploration can just correct the alignment fairly easily.
But later on, with scar tissue?
Surgical intervention for late HVOO with that dense fibrotic stenosis is much more challenging. If the obstruction causes the new liver to fail and it can't be relieved by IR or surgery, then retransplantation is indicated.
And the outcomes reflect the preference for IR.
They really do. That study we mentioned earlier reported a stark difference. Mortality was around 41.6% for patients needing retransplant for HVOO versus only 11.1% for those successfully managed by percutaneous IR intervention.
Wow, that's a huge difference.
It is. It really underscores why endovascular treatment is now considered the method of choice for most HVO cases.
So what about the long-term prognosis for patients who experience HVOO, and what are the best prevention strategies?
The prognosis, as you can imagine, depends heavily on how quickly it's recognized and treated. Acute, complete outflow obstruction that isn't promptly relieved can definitely lead to rapid graft failure and patient death.
But with timely intervention.
Survival is significantly better. That report showing roughly 11% mortality with IR versus 42% if requiring retransplant really highlights that. Graft survival after successful stenting is often excellent.
And prevention. Back to the OR.
Yes, preventing hepatic outflow problems fundamentally centers on meticulous surgical best practices. Ensuring a patent wide caliber connection for venous outflow is absolutely critical. Surgeons aim to create an anastomosis that's as large as, or ideally even larger than, the native vessel diameter.
And techniques like that modified piggyback.
Exactly.
Okay.
That modified piggyback technique, connecting multiple donor hepatic veins to a large common opening that attaches to the recipient IVC, is one method that has demonstrably reduced outflow issues.
Anything else during surgery?
Some centers, particularly in living donor transplants, routinely use intraoperative ultrasound or even direct pressure measurements across the anastomosis before closing the patient. If they detect a problematic pressure gradient right then, they can revise the connection on the table.
Proactive check.
Right. And finally, just as with the other vascular issues, vigilant Doppler ultrasound surveillance in the early post-operative period is vital for catching developing outflow problems before they fully compromise the new liver.
Okay, let's turn our attention to the last major vascular complication on our list. Portal vein thrombosis, or PVT. This seems particularly critical since the portal vein is the main highway, providing about 70% of the blood flow to the liver carrying all those nutrients.
Indeed. Post-transplant portal vein thrombosis refers to a clot forming in the portal vein connection, the anastomosis, or elsewhere in portal venous system after the liver transplant.
Exactly. Many recipients do have pre-existing PVT, but this is about new clots forming post-transplant. It's generally less common than HET, typically occurring in about 1–3% of liver transplants overall.
But maybe higher in some cases.
Yes, some centers have reported slightly higher rates, maybe up to 8% in certain series, and it is definitely higher in living donor and split liver transplants, perhaps around 3–4%. And, like HAT, potentially very serious.
Absolutely. Because the portal vein provides the bulk of the blood flow, PDT can lead to graft ischemia, persistent portal hypertension, that high pressure in the portal system, and even dangerous intestinal ischemia if the clot extends down into the mesenteric veins that drain the intestines.
Given its critical role, what are the primary risk factors for PVT after the transplant?
Well, the single biggest risk factor is actually a history of portal vein thrombosis before the transplant.
So if they had problems before, they're more likely to have them again.
Exactly. Patients who needed their portal vein clot removed, a thrombectomy, or maybe had a jump graft created to bypass a blockage at the time of transplant, they just have an inherently higher chance of reclotting afterwards.
Makes sense. What about technical issues?
Technical and anatomic issues can also lead to thrombosis. Things like venous redundancy if the donor portal vein segment used is too long and it ends up forming a loop or a kink.
Like a kink in a hose.
Precisely. Or a misalignment that causes turbulent, non-smooth blood flow. A narrowing, a stricture at the anastomosis that slows downflow is also a major risk factor. And if an artificial vein graft, like a cryopreserved vein, was used for the connection, that artificial graft itself can thrombose.
In living donor cases?
In living donor transplants, sometimes the portal vein diameter is smaller, or the vessel segment available is shorter, which can just make creating a perfect, wide-open anastomosis more technically challenging.
Okay, so pre-existing issues, technical factors. What about hemodynamic factors? The actual blood flow dynamics must be crucial for keeping that big vein open, right?
Absolutely critical. Insufficient portal flow or very slow, sluggish flow can easily precipitate thrombosis.
What causes low flow?
Well, if significant portosystemic collaterals, those natural bypass vessels that form with liver disease, were left open during the surgery, blood might continue to shunt around the new liver graft instead of flowing through it. This leads to sluggish flow and stasis in the main portal vein, which is a perfect setup for a clot.
So the surgeons need to manage those shunts.
Yes. They often try to ligate or tie off large shunts during the transplant. Similarly, if the spleen is very enlarged, hypersplenism, it can essentially steal a lot of the blood flow, reducing perfusion through the portal vein and increasing clot risk.
What about having no spleen?
Interestingly, previous splenectomy is also a risk factor. Removing the spleen can sometimes cause a rebound increase in platelet counts, leading to a temporary hypercoagulable state right after transplant.
Tricky balance. Any other patient factors?
Yes, underlying patient factors that promote clotting can contribute. Things like specific inherited blood clotting disorders, thrombophilias, or even conditions like acute rejection episodes, obesity, and diabetes might create a more prothrombotic environment.
Okay, so if that main portal vein highway gets clogged up post-transplant, what's the immediate effect on the liver and, more broadly, on the patient?
Well, PVT results in impaired blood inflow to the new liver. The liver might initially try to compensate somewhat by increasing its arterial flow, that phenomenon we call the hepatic arterial buffer response.
The liver's backup generator again.
Right. But this arterial flow really cannot fully replace the massive volume and nutrient supply provided by the portal vein. Additionally, the lack of portal inflow means pressure immediately backs up into the splanchnic circulation, the blood vessels of the gut, essentially recreating portal hypertension almost instantly.
And the worst-case scenario.
If the portal vein acutely and completely thromboses, especially right after surgery, there's a very serious risk of small bowel congestion and potentially intestinal ischemia, lack of blood flow to the intestines, particularly if the clot extends down into the superior mesenteric vein. That is a life-threatening surgical emergency.
Does timing matter here, too, like with HAT?
Yes, the timing influences the pathophysiology. An early PVT within the first few days often suggests a technical issue at the anastomosis. Acute graft ischemia and even infarction can happen if it's not fixed promptly.
And later PVT.
In contrast, a late PVT, occurring months to years later, is usually more insidious. By then, some collateral circulation often exists, so the liver might continue to function, albeit usually with ongoing signs and complications of portal hypertension.
And the bile ducts. Are they affected like in HAT?
That's an important distinction. The bile ducts get the majority of their blood supply from the hepatic artery. So unlike HAT, PVT typically does not cause that kind of severe biliary necrosis.
Got it. So what about symptoms for someone with PVT? How does it typically present, and what are the key things doctors look for?
The presentation can really vary dramatically. It can range from being completely asymptomatic, just found incidentally on routine surveillance imaging, all the way to that life-threatening mesenteric ischemia we talked about.
What about acute early PVT?
If the portal vein acutely and completely thromboses soon after transplant, the patient may develop signs of acute liver graft dysfunction. Rising liver enzymes, maybe reduced liver synthetic function. More noticeably, though, you'll likely see features of acute portal hypertension. Rapidly developing ascites, intestinal edema causing abdominal distension and pain, and possibly gastrointestinal bleeding.
And the mesenteric ischemia signs.
If the clot extends and causes mesenteric venous thrombosis, then signs of bowel ischemia appear: diffuse abdominal tenderness, maybe bloody diarrhea, and signs of systemic infection or sepsis.
Okay. What's a key takeaway clue for PVT?
Here's a really significant one for you. Persistent or recurrent signs of portal hypertension in a liver transplant patient, especially if those signs, like ascites or varices, had initially resolved right after the transplant. That should make you highly suspicious of PVT until proven otherwise.
So reappearance of old problems is a red flag.
Absolutely. Chronic TVT can lead to the formation of a whole network of new, small, twisted collateral vessels trying to bypass the blockage. This is called a portal cavernoma.
The body's attempt at a natural bypass.
Exactly. Patients with this chronic state might be relatively okay at rest, but over time they're prone to redeveloping complications of portal hypertension. Bleeding from varices, vomiting blood or passing black stools, recurrent ascites, and overactive spleen, hypersplenism.
Okay, so how do they actually diagnose PVT, and what's the gold standard for confirming it? Same tools again.
Pretty much the same initial approach. Doppler ultrasound is again the first-line diagnostic tool.
What does Doppler show in PVT?
Well, normally, portal flow on Doppler is hepatopetal flowing towards the liver. In PVT, Doppler might show a complete absence of flow in the portal vein, or sometimes even hepatofugal flow actually reversing away from the liver through collaterals. Sometimes you can directly visualize the echogenic thrombus, the clot itself.
And if the ultrasound is suspicious or maybe unclear?
Then usually a contrast-enhanced CT scan, specifically timed for the portal venous phase, is performed. This will clearly show a filling defect, a blockage in the portal vein, perhaps at the anastomosis or extending into the branch vessels. MR angiography or venography can also be useful alternatives.
And for intervention?
Portal venography, where a contrast dye is injected directly into the portal system, often via a transhepatic or transplenic approach, or sometimes via TIPSIS, is the next step if an intervention is planned. It allows direct visualization of the clot any remaining channel and facilitates therapeutic measures.
Right, treatment. What are the key strategies for PVT once it's confirmed? How do doctors go about reestablishing that critical inflow?
Well, the management really depends quite a bit on the timing and the severity.
So early post-op PVT.
In the immediate postoperative period, let's say PVT detected within the first 1 to 3 days, many surgeons will opt for surgical intervention. The abdomen is already recently operated, relatively accessible.
Makes sense to go back in quickly.
Often, yes. The surgeon can open the anastomosis, perform a thrombectomy to remove the clot, and then carefully redo the portal vein connection. This early surgical revision actually has a pretty good chance of success if done promptly.
What if it occurs later, or maybe a less invasive approach is desired?
Right. For PVT that occurs beyond that immediate post-op window, or even for early PVT, if the patient is stable and seems suitable, then interventional radiology procedures become the frontline option.
What can IR do here?
Techniques include catheter-directed thrombolysis, delivering TPA or other clot busters directly into the portal clot, often accessed via a TIPS procedure or a direct transhepatic puncture. This might be combined with balloon angioplasty or stenting of the portal anastomosis if there's an underlying narrowing.
What about TIPS itself as a treatment?
In some scenarios, particularly for more chronic PVT or when direct clot removal isn't feasible, creating a TPS that shunt connecting the portal vein to a hepatic vein inside the liver can be done primarily to bypass the portal clot and decompress the portal system. This can be really helpful for controlling complications like variceal bleeding and ascites, sometimes as a bridge to other therapies.
What if it's just a small clot found incidentally?
If a small non-occlusive PVT is detected and the patient is stable without major symptoms, the initial management might simply be systemic anticoagulation therapeutic doses of blood thinners, typically for at least 3 to 6 months, sometimes longer.
And anticoagulation is used after interventions too.
Yes, anticoagulation is almost always used as an adjunct after any surgical or IR intervention for PVT to help prevent rethrombosis.
And if all else fails?
If PVT leads to irreversible graft failure, or if the clot simply cannot be effectively resolved and is causing severe complications, then retransplant remains the definitive, albeit rare, solution.
So the sources kind of summarize the approach based on timing.
They do, essentially. If thrombosis is seen very early, like the first 72 hours, surgical revision is often preferred. Later on, the first attempt is usually with less invasive percutaneous techniques like thrombolysis, angioplasty, or stenting. Surgery is reserved if those fail or aren't possible.
Okay. What about the outcomes for patients with PVT? And crucially, what are the best strategies for preventing it from happening in the first place?
The outcome after post-transplant PVT really depends on how extensive the clot is, how quickly flow can be restored or compensated for, and whether complications like mesenteric ischemia occur.
So early fixed PVT can be okay.
Yes, early PVT that is promptly and successfully treated can result in a near-complete recovery with good long-term graft function. Untreated complete PVT, however, can certainly cause graft loss and even mortality, especially if that dreaded mesenteric ischemia develops.
And the more chronic or partial PVT?
Late or partial PVT usually doesn't outright kill the graft in the short term, but it can significantly impair quality of life and potentially shorten the graft's lifespan by causing those persistent portal hypertension complications. Though with good ongoing medical and endoscopic management, like treating varices, patients can live for many years even with a portal cavernoma. The literature generally suggests that with prompt, appropriate management, the overall outcomes in terms of morbidity and mortality are actually quite satisfying these days.
It's encouraging. So prevention, what are the pillars there?
Preventing PVT after transplant starts even before the surgery. Careful preoperative assessment, maybe imaging to understand the portal vein anatomy, and managing any pre-existing portal vein issues is key.
And during the transplant itself?
During the operation, surgeons focus on optimizing portal inflow. This might involve ligating those large portosystemic shunts that would divert blood away from the liver and, of course, meticulously creating a wide-open, non-kinked portal vein anastomosis to ensure good, smooth flow into the graft and reduce stasis.
What about after surgery? Medications, monitoring?
In the immediate postoperative period, some centers advocate for early anticoagulation or antiplatelet therapy, particularly in patients identified as being at high risk for PVT, like those with prior PVT or complex reconstructions. And once again, routine ultrasound monitoring is incredibly valuable. Early detection of developing sluggish flow or a small partial clot could prompt preemptive anticoagulation or early intervention before it becomes a major problem.
So summarizing prevention, Manage pre-existing issues, optimize surgical technique and flow, consider prophylactic anticoagulation in high-risk cases, and vigilant imaging surveillance.
That's it, exactly. Those are the pillars of PVT prevention post-liver transplant.
Okay. So what does this all mean for you, the learner, now that we've taken this pretty deep dive into the liver's most critical vascular challenges after transplant?
Well, if we try and connect this to the bigger picture, I think it means that while liver transplantation is undeniably a life-saving miracle, it's also just a profound testament to incredible surgical precision and the need for constant, unwavering vigilance afterwards.
Yeah.
These vascular complications, HAT, HVOO, and PVT, even though they're relatively infrequent in the grand scheme of things, they demand a really high index of suspicion from the clinical team and require aggressive, swift management when they do occur.
It's truly amazing, though, how advances in surgical techniques, and particularly as we've discussed in interventional radiology, have just dramatically transformed the outcomes for these potentially devastating problems.
Absolutely.
As we saw in the sources, timely IR procedures now salvage many, many liver grafts that would have almost certainly been lost in previous eras.
That's right. It's become a crucial part of the toolkit.
It really highlights that it's a remarkable multidisciplinary symphony, doesn't it?
Right.
You've got the transplant surgeons, the hepatologists managing the liver disease, the interventional radiologists performing these amazing procedures, the intensive care specialists, all working in concert to optimize patient results and ultimately offer that second chance at life.
It truly is a team effort, and maybe this raises an important question for you, our listener, to kind of mull over. In a field where literally every milliliter of blood flow, every millimeter of a surgical connection can mean the difference between life and death.
Yeah.
How much further can precision medicine push these boundaries, particularly in terms of prevention and even earlier intervention?
Yeah.
It really leaves you thinking about the incredible human ingenuity behind these medical breakthroughs, but also that constant delicate balancing act between the inherent risks of major surgery and intervention and the immense life-changing rewards of a successful transplant.